I can hear you.
Okay, right, fine. So there are some things that I think we should all collectively carry on doing. Next slide. So as Colette said, not her again, this is the original picture of a patient with PBC. So PBC was described, it didn't get the name in 1857, but it was described in 1857. So about 160 years ago, PBC, and this is a picture of the lady with it. And it's a fascinating description. And there are many aspects of it that we would now recognize today. Although interestingly, when Addison and Gold described it, they thought it was a skin condition, very much around the xanthelasma, those fatty deposits around the eye, which we see very occasionally now with PBC, but not frequently at all. Seems to be one of those things that's improved with Urso. So it was there for a very long time, but it went through a number of different iterations. And I think this is the point on the right, which is very important. So having been originally thought of as a skin disease, it was then thought of as a very severe liver disease, the Sheila Sherlock era, when people with PBC were thought of as having all of the features of cirrhosis, jaundice, ascites and varices and things. We now know, however, that that's a very rare phenomenon in the disease. The vast majority of people don't develop advanced liver disease. But the next problem set is much, much more important, which are the features that can be seen in all people and those features that can impair quality of life. And Vinod, my colleague, is going to talk about pruritus a little bit later. And our focus is on fatigue and what we call cognitive dysfunction, which are problems of memory and concentration. And so whereas cirrhosis is something that affects a small number of people, these symptoms are something that affect the majority of patients and therefore need to be taken very seriously. And there are, of course, a group of people, which is fantastic, who don't get any symptoms or progression. And the problem we have with all people is knowing who is at risk of what in the future, so that we put everything in place in case there are problems in the future. So it's a very important component of PBC to think of quality of life and what we can do about it. Next one. Okay, so I'm going to cover three things today. One is, where are we now? So what is state of the art as in terms of what we do now? There are some things we need to do right now, some things we need to change, which we can change now. And I'm going to give you a little peek into the future. And I called the talk Light at the End of a Long Dark Tunnel, because I think there is some light. And I learned a long time ago that people want to hear about the science and where it's all going, because it allows them to see what the opportunities are going to be. So I'm going to present you with some of the experimental data we have and where this is going in terms of therapy. And I hope you'll find that interesting. Like much science, as we're discovering at the moment with COVID, science does not always pan out the way you think it's going to, but we have a pretty reasonable idea that it will. So I'm going to show you some data around that, which hopefully you'll find interesting. So just go through two now, Robert. So the first is where we are now. So just move on again. So this is some work we did from UK PBC, and you'll see this come up all the time. UK PBC is a group of 8,000 patients across the UK. Many of the people on this call will be in UK PBC, and it was set up to understand the nature of the problems in PBC and what we can do about them. And it is across the UK, all hospitals in the UK are involved, PBC Foundation and the other charity groups are integral to it. So it's been a great community effort. And it has been one of the things that has led to a number of the therapy advances we now see in PBC. But it's always been interested and focused on people and their needs and their problems. And so quality of life, the totality of your life experience and the extent to which it mirrors what you want, hope for, and reasonably could expect is a big focal point. And we've been working on that now for a number of years, as I'm sure a lot of you will know. If you just ask people about their quality of life, there's a simple way of doing it. What you find is this. The blue line is the average, the pink lines are the confidence intervals. And interestingly, a poor quality of life, is your quality of life good or impaired by PBC? That's the yes or no here. What you find is that an impairment in quality of life is very common in PBC at all ages, but actually it is particularly common in younger patients. And this is, I think, a combination of the disease itself. It was a disease itself, but also the expectations that people have at different stages of their life. So like a number of the things that we do in PBC, we are particularly focused on younger patients, but it's a problem potentially across the board. But look at that, there is a proportion of patients with normal quality of life and no symptoms. And I think that tells us it is perfectly possible to have no symptoms in PBC and a good quality of life. So that's the goal we're working towards. Next slide. So a number of years ago, we developed a thing called the PBC-40, long before UK PBC, and we did it in order to understand the impact of the disease, and importantly, to develop tools that we could use in trials to improve the disease. And this was the era when nobody was interested in doing trials of PBC, and this was when URSO was just coming into use, and no companies or researchers were particularly interested in it. So it was a little bit of a shot in the dark. And this was important for a number of reasons, because this was the first collaborative research done with the PBC Foundation. So this was done with the PBC Foundation with a grant from the National Lottery in the UK. So no other funders would give us the money to do this, but the National Lottery did. And this has underpinned almost everything else we'll talk about today. And one of my abiding memories of PBC, and Colette knows what I'm going to say now, is finishing writing the grant for this in a pub in Berwick-on-Tweed. So I live in Newcastle, Colette in Edinburgh, and Berwick-on-Tweed is the middle point. So it's the only time I've finished a grant in a pub. So there you go. Very successful, but has been a major role in understanding these symptoms. When the approach you take is to interview patients, so you use interviewers who don't know the disease at all. They don't understand the disease. They're not there to do that. They're there to allow people to talk, and these are recorded interviews. And so people are allowed to talk about the disease and the way it impacts upon them. And what you then do is what's called thematic analysis. So you put together all of the interviews, you extract all of the text, and from that, you put it into a computer and themes emerge. And from those themes, patterns of things that people say emerge. Okay. From all of that, you identify patterns of statements which are in symptom areas. And this is where fatigue, social, itch, cognitive, and emotional come from. These are patterns of symptoms people describe in PBC. So we didn't ask people about fatigue in deriving the PBC-40. They told us about it, but there were certain things that lots of people said that always seemed to go together. So the important point about this work is that it wasn't clinicians saying, I think these symptoms are important. These are the expressions of patients. It's what's called a patient-derived measure. And a lot of clinicians doubt fatigue as a problem, but remember this point. This came from the statements of people at the beginning. And when you do this, there are some themes that come out. Fatigue is the commonest symptom. Over 50% of people have moderate or severe fatigue, but also cognitive symptoms, these symptoms of concentration and memory, and also social symptoms, social isolation for people and the impacts. And those are all really important things as we move through into how we manage this in practice. And the danger that people become socially isolated is there with PBC, makes all their symptoms worse. And it's why we've been particularly bothered by COVID and its impacts. So these are the symptoms of PBC. Next slide. When you look at how they all fit together, in fact, there are three patterns in PBC. Itch rather sits on its own. And then you have a combination of fatigue, cognitive symptoms going together. And that's because mental tiredness and fatigue will overlap. And then you have this overarching problem with social. So people feel like they can't go out if they haven't got the energy to go out, or they can't go out if they're perhaps a little bit bothered by scratching because of the pruritus. And actually, one of the goals of all of our therapies is to improve social symptoms, because once people are able and confident to go out, then their quality of life will improve. So it's one thing saying your fatigue is less or your itch is less, but if you don't go back to a more normal life with it, it isn't that much better. So symptom assessment is a really complex way of understanding the disease. Okay, next slide. Now, I'm not going to read this out, but this was something written by Tilly Hale, who is someone that many of you will have known. I knew for many, many, many years, and sadly she passed away. Nothing to do with her PBC a number of years ago, but is somebody who had the needs of PBC patients at her heart. But she thought very carefully about PBC, and she got very angry about doctors and PBC, and we'll come to some of these issues a little bit later. And so she wrote this piece in the BMJ, which I wrote with her. And the reason I show this is that the percentages of people affected in particular ways are very dry. 51% of people get this. These are the words of people, and they speak in a very important way. And I'll come back to some of the themes that she brought out because it's really important. I show this slide very frequently because numbers can hide the real impact on people and their lives. So we have to convert this to I feel great before we've really won in terms of these symptoms. But I will come back to some of the themes in a second. Next one. In fact, I'll do it now. So the themes that I think come out from this, the first is talking about tiredness and fatigue. So tiredness is a normal state that we all get in response to various different aspects of what we're doing in our life, but fatigue is abnormal. Clinicians really struggle to distinguish between the two, but patients in my experience are very good at that. And so one of the things that we have to do is to listen to people when they say that this is not tired, this is fatigue, because although those terms in a dictionary may look very similar, people tend to know the difference. The second theme that comes out from this is a lack of understanding from clinicians and, I have to say, family members. And actually a lot of patients with liver disease in general, particularly with PBC, don't talk to their clinicians about their fatigue because they know the reaction they're going to get. I think that's one of the reasons why some clinicians think it doesn't exist. People have learned not to mention it. I will come back to that in a second. Severity of the symptom, fatigue is mind numbing, okay? So that is a very powerful expression. And certainly we come across people whose lives are profoundly affected by this. And I think, again, sometimes clinicians can miss this. There is an inherently complex nature to it. There are central peripheral components. You feel as if you're in a fog, you can hardly lift one foot in front of the other, everything's so difficult. So there is brain fog, struggling to think through things, which is very much brain function, but at the same time, you can hardly lift one foot in front of the other. Very physical and power thing. And these are very much two flavors, as I call them, of fatigue and PBC, and they are slightly different, and we need to think of them slightly differently. Degree of functional impact. So it isn't just I feel tired, it's the way it impacts on life. So fatigue is really important if your food defrosts because you're too tired to put it away. So it's capturing functional impairment, not just emotional response to it. I can't do X, Y, and Z because of my fatigue. And we find this all the time. Challenges with people with their particular jobs or people who've got a wedding to organize or something like that. That's when the fatigue really hits home, when it impacts on function. And then the really important thing we'll keep coming back to, which is the distinction between fatigue and depression. Those are the words of a frustrated lady, not a depressed one. And I think we need to absolutely move away from this being sort of rather lazily ascribed to depression. But we'll come back to all of those things. Next slide. Boom, boom, boom. So two flavors, peripheral fatigue, my battery's run down, I feel like I've run a half marathon, I can't lift one leg in front of the other. Central fatigue or brain fog, I can't think my way through it, I can't remember things, etc. Challenges with all of this, different people use the same term for different things. So one person will describe their muscle issue as fatigue, another person will describe their brain fog as fatigue. So we need to be aware of that. People can use different terms for the same thing, fatigue versus tiredness, as we talked about. And it is best to think in terms of concrete aspects rather than abstract terms. So in a way, how severe your fatigue is quite an abstract concept. But if you are struggling to go to work, struggling to look after your children, those are much more concrete things. And understanding those benchmarks is a very important thing, because it does allow us to quantify it. It does not negate the experience of people, but it allows us to benchmark it to understand where improvements are. Simple thing I do is ask people to think each year about their summer holiday or Christmas, and think about what they were able to do on those holidays or at Christmas, and has that changed over a year. It's very easy for people then to think, oh, well, I was able to have friends around or whatever. It's a slightly more concrete concept, so we use that all the time. Next one. Now, one of the things that surprises everybody and creates all manner of problems, okay, is that fatigue is unrelated to liver disease severity, as simple as that. So this is the UK PBC data from Marco, who I think you heard from earlier. If you look at alkaline phosphatase, you know, very much beloved of response to URSO and measuring PBC, there is simply no association with how bad fatigue is and how high the alkaline phosphatase is. So if your doctor says, but your alkaline phosphatase is fine, it can't be your PBC, there is no relationship. PBC is far commoner, fatigue is far commoner in PBC patients than it is in age and sex matched people in the population, but it isn't associated with how bad the disease is. Next slide. It similarly isn't associated with any response or non-response to URSO, UK PBC data again. What I've pulled out here is that people will be familiar with URSO responders and non-responders and people who don't have URSO, but the fatigue number you can see here is identical between them. So URSO does not change fatigue at all in PBC, and I think that would very much fit with what we see in practice. Some people will feel better, some people will feel worse, but overall there is no difference. Next one. And probably the most disappointing thing in my career to date is this, which is the failure of obeticholic acid when used in the big trial to also have any impact on fatigue. Maybe you know, the smallest of hints in various people. But when we used OCA, obeticholic acid or Ocaliva, in people who'd failed URSO therapy quite late on in the disease, it does not improve fatigue, and we had high hopes that it would. But I will come back to this right at the end of the presentation, because although this is one of the negative things, this actually does lead us on to the light at the end of the tunnel. Next slide. And here is something very important from Greta Pels in our group, who was a student who worked with us, and she looked at people with PBC having liver transplants. And if you look on the left, these are UK PBC patients and matched transplanted or non-transplanted patients, matched for duration and age. What you see is the fatigue number is the same between them. Now, people who go to transplant tend to have much more in the way of symptoms as part of their cirrhosis. But when you have a transplant, there is a danger that you return to the level of functioning you had that was typical of a PBC patient, okay? So you do not go back to normal in our experience. You improve from how you were just before the transplant, but there will stay problems. And if you look at the men, much smaller numbers, in fact, their fatigue was worse after transplant than it was beforehand. And just one aside, Tilly's words that were so very powerful, she wrote those many years after having a liver transplant, describing the symptoms she had post-transplant, which she felt hadn't really changed with her transplant. Although she was very grateful for transplant because other symptoms had gone away and it undoubtedly prolonged her life. Next slide. Now, two things really important in all of this. First is people get very sleepy during the day, daytime somnolence. This is a thing called the Epworth score. This is a measure of sleep during the day, and a level of 10 indicates quite a significant sleep disturbance. And if you sleep during the day, you feel fatigued. So sleepiness is a feature of PBC patients with fatigue. We'll come back to that later. Next slide. And as is a problem called autonomic dysfunction, which is a tendency for your blood pressure to drop when you stand up because you're unable to regulate your blood pressure. And it's quite a subtle observation, but PBC patients tend to have more in the way of autonomic dysfunction, more dizziness when they stand up and blood pressure problems than do other people in the population. The importance of this I'll come to in a sec. Next one. So what do we do in practice right now? We do a thing called TRACE, treat the treatable, ameliorate the amelioratable, cope and empathise. This is really important. This is our practical approach. First slide, next one. So the first is treat those things that are there, which is going to make the fatigue worse. If you're itching at night, treat that. If you've got anemia through thyroid disease or through pernicious anemia or celiac disease, treat that. Those are all associated with PBC. And if you've got diabetes or heart failure, not associated with PBC, but they also cause fatigue and they tend to happen in people at the same age of PBC, treat those. So first of all, treat those things that are there and treatable. Next slide. Then there are some things that go along with fatigue. They are not directly part of it, but they make it worse, and they are features in PBC. This is why sleep disturbance is very important, and that autonomic dysfunction that I talked about. Some really simple things you can do are just think about fluid intake, drink a little bit more fluid during the day to increase blood pressure. And we do ask people to go through their blood pressure medications with their doctors, because they can sometimes be unnecessary once you've got PBC, and they can all improve this blood pressure regulation. And then we send a lot of people to the sleep clinic to look at their absolute pattern, see if we can help them. There is some depression in PBC, I'll be the first to admit it, but it is usually secondary to frustration people feel because of their fatigue. And so what we tend to do is to treat that as part of the contribution. But we're very clear with people, you are not fatigued because you're depressed, but sometimes you can be depressed because you're fatigued. In our experience, antidepressants are more effective than talking therapies. Next slide. Really critically important is what you can do with it, which is coping strategies, energy management, planning the day so that you can manage your fatigue, treat it like a valuable resource. Fatigue is much better in the morning and gets worse during the day, so plan your working pattern around that. And we can help, or we do help our patients with employers, with employment patterns and things like that. What's really important is owning the problem. You own the problem, you own the solution, and we work with you to help you to do that. Remember what I said about social structures, very important to build and keep those because they are integral to your quality of life. That's why I'm so committed to these sorts of events, because they are actually a social networking thing in a time when people struggle to meet up. Exercise is important. It will help reduce some of the aspects of fatigue, and it's good for all-round health, and we're very strongly supportive of it. So own the problem and own some simple practical solutions that help you live through it. Next one. And then finally, this is what we tell the doctors in training: empathize, okay? Empathy, people want empathy, not sympathy. People want the doctors to understand it's a really horrible thing, and don't enter into those discussions about it which are really unhelpful to people about its reality and severity and comparing it to their own life. So we train doctors to really be very empathetic about this. Okay, next slide. Now, here are some things that and when you pull all of that together into a pathway, if you do all of those things in the clinic, then in the top right-hand corner, you can see over the space of a year, you will improve fatigue severity in people in your clinical service. So none of these is a miracle treatment. Put them all together, they work. Okay, so it's well worth doing all of these things. Next slide. And one of the priority things we did is to include assessment of fatigue in the clinical guidelines we have on the right. So now the European guidelines say that fatigue should be assessed in all patients with PBC once a year, even if it's the doctor just asking you about your fatigue, but it is a normal part of management. Next slide. Now, what do we need to do right now? What are the problems that we can really start to address? Next slide. The first is the things that doctors say. We have to push back that this isn't real and isn't a problem. You look well, what's the problem? Your blood tests are fine, so it can't be your PBC. Everyone gets tired. I was on call last week. These are all things PBC patients have had said to them and reported to me. I only treat proper disease. That's a nice one. You're only tired because Dr. Jones tells you are. I'm a vaguely persuasive person, but I don't particularly believe that one, particularly people across the UK that I've never met. But the pièce de resistance one, next slide, this is a real winner. They are just middle-aged women. What do you expect? And I, for a small fee, can tell you who said that, okay? That's a doctor said to me, they are just middle-aged women. What do you expect, all right? So we have to push back at that. Next one. There is an issue with clinicians about thinking about this, but there's also an issue about getting treatments out there. And I won't talk much about this, but Vinod will talk this afternoon about it. This is the reach of itch treatment for people with significant itch in the UK. Now, itch is in many ways easier to treat than fatigue. And yet most people in the UK with significant itch do not have effective treatment for it. So actually getting treatments out there is a really important thing. So we use rifampicin widely for itch, and yet the numbers of people with significant itch getting it are tiny. And only 30% of people with significant itch in the UK had ever had any therapy for it. So it's a real issue in the real world. Next one. There is also an issue amongst clinicians and confidence with new therapies. You hear a lot today about OCA and bezafibrate and how we use second-line treatment. This is something we published a few years ago, showing that only about 40% of the doctors who prescribe these drugs are confident about what they should do. So there's a real need to increase awareness about how you treat all aspects of PBC. Next slide. And Jess Layton, who works with us, is on the call. I see her putting text through all the time and tweeting away. This is a really nice piece of work she did with the PBC Foundation about confidence of people to address limitations in their care in practice. This was around whether you asked about your alkaline phosphatase or whether it was discussed with you. The whole of therapy really relies on alkaline phosphatase values, so was it discussed with you? And what she found is there was a sort of a core of good practice, but there is poor practice, and people lack the confidence to identify what it is they should be asking about. And so empowering patients to ask the critical questions is something that we want to do much more of. Next slide. And I had to mention the book at some point. And I finally did over lockdown what I said I would do for many years, which is to write a book with everything I know about PBC written into it. And it's no surprise that it has the longest chapter is on symptoms, but there is also a whole chapter on living with PBC and the things that you can do to help yourself. So this theme around empowering you to help yourself adjust to it all is a really important part of it. And this is hopefully useful to people, and as we put here, we're sharing the proceeds after Jeff Bezos has taken his proportion. So I hope people find it useful. It's out there and available on Amazon. Next one. So where does this all go in the future? And this is where it all gets really exciting. Okay, there are a number of drugs coming along which are interesting. This is an old one, S-adenosyl methionine, SAMI, or Adamet. It goes under lots of different names. And this is data from 30 years ago. It's the largest ever trial in fatigue. There is now really good reason to think that it's a type of vitamin, that it will help with fatigue because it prolongs the ability of the muscles to work. And we are working with the company concerned to develop a trial in this, and we're very optimistic it will happen. For those of you in North America, this is actually available in sports shops. It is a nutritional supplement used by bodybuilders. It's very safe. So it's not available in the UK. We're working on it, but it is available in North America, and it does have quite good evidence behind it. So that's one of our target agents. Next one. But the other one I think is deeply exciting, which is going to be obeticholic acid, but used in a different way. To get to that point, we've done some work mapping what it is that impacts PBC patients. So this is some work we've done in Newcastle doing cognitive tests. These are memory concentration tests done on a computer. And when you do this, you find that PBC patients are bad at paired memory, trying to remember where two things are: working memory and strategy, attention and data processing, emotional recognition, what does a face say, problem solving. So people struggle when they see something and then have to interpret it and act. But at the bottom, people are better than normal people in the population at just doing a straight visual response. So people are not physically slow, they struggle with processing. This is really important. Next slide. We've also done some work on brain imaging, which will allow us to start to identify the parts of the brain that aren't really working. Now, we don't do much animal work, but sometimes you have to really make a difference and kick on. And this is some work we did with mice that have cholestasis, the process you get in PBC. And the details of the test don't really matter, but when mice are cholestatic, they develop they develop brain fog and they can't remember the environment that they're in. So it's actually quite a useful system to be able to test what is happening in a disease like PBC. So what you're looking for is a number around 67%. That shows that the animals are normally inquisitive, remember something, and a value around 30% is where the animals have forgotten what they saw before. So those are the two values to remember. So simply they can't remember something they'd seen which had a treat in it. Next slide. The really interesting thing is on the left, prophylactic obeticholic acid or therapeutic obeticholic acid, one is given before they become cholestatic, one after, takes the value right up to the green line, which is normal, compared to the red line, which is abnormal. So the bar that ligated just the cholestatic animals remain abnormal, but obeticholic acid given very early in the disease returns these animals to normal, whereas ursodeoxycholic acid doesn't. So obeticholic acid will in fact reverse brain fog. Next slide. But only when given early in the disease process. And so obeticholic acid was disappointing because it didn't work, but it didn't work, we think, because it was given too late in the disease process when the effects on the brain were not going to be reversible. So there is a very clear way through. Obeticholic acid, but does not reverse this process. So OCA seems to reverse brain fog in cholestasis early in the disease. Next slide. And bezafibrate does not do the same as obeticholic acid. And there is a very complicated mechanistic reason why this is the case. And I think there's a lot of debate now about where bezafibrate and obeticholic acid sit. And I think there is no question that bezafibrate is better than obeticholic acid with regard to itch. Bezafibrate improves it, obeticholic acid makes it worse, but I suspect very strongly that early use of obeticholic acid will be effective in treating brain fog and central fatigue, whereas bezafibrate won't. Next slide. And then all of this is interesting but frustrating for people unless we do something about it. So I'm pleased to say we're about to announce the trials in the UK called OAKS 1 and 2. OAKS 1 is patients, that's obeticholic acid for cognitive symptoms. This is for patients with new onset PBC, and OAKS 2 is for patients with established PBC, but with significant memory and fatigue symptoms. And we will once and for all ask whether the earliest possible use of this drug will make a big difference. So all of this science sits in a bubble on its own, but it is now moving forward into clinical trials. And none of this would have happened without our understanding from patients and all the tools that we developed. So we are now in the era of understanding what's happening in people, accepting the reality of it, using simple practical tools to help people right now, but moving towards the definitive therapies that plugged into that system hopefully will make a profound difference. And to me, that's the light at the end of the tunnel. At that point, before I get told off by Robert, I will shut up and take questions. But I hope that was interesting for people.
Can I come to you first of all with a question, because I will disappear. But the subject of exercise is very important. As you know, we practice movement as medicine, given what we learned from your Professor Chanel in Newcastle, how this benefits people with PBC. Yeah. Now, I'm coming in at 6 o'clock with a trainer, Roma Ferguson, she's done it for us before, but she's going to be helping people who have mobility problems, some chair aerobics and how, so with the exercise, I know you can't tell people how much to do. How often would you recommend people do it, David? Because it's something we get asked all the time.
So if you go into the science literature, you can make, so there is a whole literature of sports science, which is very relevant to this. So the work they do for athletes about the biology of exercise. So exercise has profound biological effects on the brain and the muscle, okay? And the sports science people will tell you 10% more than you do now. So in order to continue to improve, you have to do 10% more. So if people are walking a mile, you need to walk a mile and 10%. So it is about not launching into a very aggressive exercise campaign from scratch. It is by gradually increasing it. So if you're doing one exercise session a week, go to 2 a week and things like that. I don't think it's practical people to do it more than 3 or 4 times a week. It's not practical people to do it more than about 20 minutes or half an hour. But if you haven't been, highly active before, that sort of level will make a real physiological difference. The key is to keep going at it.
Right.
So this change builds over time, but it also slips back very easily. So it's a case of just building and building and building and building. The problem is, if you get very good at it, that 10% increase becomes progressively more difficult, and it can become quite time consuming to do that. So it is incremental build over time.
Okay, thank you. Robert, I will hand over to you.
Wonderful. No, thank you both very, very much. Is this the book we were talking about?
Yeah. I bought you that through the week.
Right.
Just everybody, this is a bit of a standing joke about the book. It was, I did it because actually it went on Amazon, and you could buy more T-shirts about PBC than you can books. And I've been, blithely suggesting to people that they get a book and read about it, and then I realised there wasn't one. And that was actually, my wife pointed out, well, don't moan about there not being a book. Why do you write one? So rather than learning to play a musical instrument in lockdown, that's what I did.
Interesting. I've bought 3 and I don't own a copy, right? Giving them away.
On a more serious note, we were actually asked about the book, so this is why we're sharing it with you.
Yeah.
Definitive guide for patients with primary biliary cholangitis.
Pull it back. Pull it back. Right.
And there is, it's about to be changed to include the foreword from Colette that she very kindly wrote. And the idea is we're going to update this, so keep it updated. The way in which you do it with Amazon means it's actually bang up to date, so it doesn't take long to get it through and out. Wonderful. And the idea is we'll update as it. I think in it we've included, in a sense, what I've known, and then there's a dictionary of PBC for these terms that keep cropping back. But then I put at the back was all our protocols. So I've written down all our approaches to the management. So things like trace is all covered in that. Right at the back, which is the Newcastle approach. So this is what we do in our clinic right now to manage all of these things. And as I say, it's really important. I'm not telling anybody how to manage PBC, and it's very important that you discuss your individual needs with your doctor. But this takes the guidelines and converts it into real world practice. There's nothing in here that's not in the guidelines, but it in a sense makes it understandable, I hope, to people. But it also says what we do in practice. So the protocols convert guidelines into what first we do this, then we do that, then we do the other. And I think that's what people want. So I think it's a good starting point. And I think it's quite useful if people are not doing the things that we say in this, then it's a good question, why not? And I think, remember what I said about significant numbers of people with itch. Itch is important because it should be well treated by everybody, as Vinod will say, because it's easy to treat. And that may come as a surprise to lots of people on this call who maybe are struggling with it. It's easy to treat, but only if you take it seriously and do it properly. So what we're trying to do is make it easy for people to do it properly. That's not, it's not rocket science, that.
Wonderful, thank you. Okay, so we are at close to 1 p.m. and we are on time. So we're going to keep this way. And what we're going to do is going to fire a number of quick fire questions to...
This is another standing joke, my response to quick fire questions, but I will be quick fire today.
Dave, we've had a couple of questions about ODCA. So can we please clarify UDCA and OCA, please?
Okay. So the slide, I've just realized when I went through the slides, has a typo on it. So in the mouse stuff, it was UCDA was a typographical error. It was UDCA. Okay, that's URSO. Okay, so I do apologize for that. It's when you stare at your slides and realize there's a typo in it. So UCDA is me with a typo for UDCA. That's ursodeoxycholic acid, or URSO. Okay, and OCA is a beta-cholic acid or Ocaliva, or INT 747, which is the old name. So we tend to use OCA because we don't use the trade names in practice. So OCA is a beta-cholic acid, UDCA is URSO, and UCDA is me being an idiot.
Wonderful.
£10 penalty then, I think, Robert.
I think that's a cop, actually. 20 for that.
So right, that's helpful. And again, thanks to Jess, who is
Jess has been marvelous.
So she's putting your answers in short form, which is great. So next question is sudden onset fatigue. So this is where patients are well and good, having a great day, and then suddenly, and again, the common parlance is the power's being pulled.
Yeah.
So what can you talk about that, please?
So this late onset during the day is characteristic. So people often, what's the difference between chronic fatigue syndrome and PBC fatigue? There is a profound difference around the kinetics of it. So PBC is very characteristic. People are fine in the morning and then run out of power during the day. What we think is that there is actually, and that is more characteristic of peripheral fatigue. So that's more characteristic of the energy-driven one, although we think that the central fatigue is energy to the brain. I remember talking to a patient who was a very good runner, and so had run competitively, half marathons and marathons. And she said the feeling she got with her fatigue was identical to hitting the wall in a marathon. Okay, so we actually did some work around measuring muscle acid levels. Okay, and in fact, what people are doing is developing lactic acid in their muscles, just the same as long distance runners. So when she said it was just like hitting the wall in a half marathon, that's exactly what it was. Okay, so that is all of a sudden your muscle can soak up a certain amount of lactic acid and compensate, but then it just reaches the point it can't, and the muscle pH becomes too acid, and when it's acid it potentially damages the muscle, so the body switches itself off for that reason. So you literally have been creeping up into that dysfunction, and then the body said, hang on a second, stop damage the muscle. That is the thing that improves best of all with graded exercise, because that's what the athletes do. So that's, if you're getting that, then gradually building up exercise over a length of time, but never reaching that point of hitting the wall is the way to do it. So you gradually build it up, and each time you do it, and it's a medium-term commitment to do that. But if you do that, you find it will do it. We think the autonomic dysfunction, the blood pressure thing, is all about the blood carrying the lactic acid away. So it's part of all of that. So the hitting the wall thing is the one that training works for best of all, and I think it therefore is a case. And in fact, when I said the 10% more than you're doing before, that was literally the regime that we use for that. So just a slow build up. Somebody passed a question about S-N-sarmethionine in the comments. Will that help with that? The answer is that yes, it will, because it's part of energy generation in the muscle. So S-N-sarmethionine is part of the energy generation pathway. And so the anticipation is it would do that, and I didn't show it, but there's some evidence from sports again that it will reduce lactic acid in muscles. So that's why it's sold in fitness shops. And then the other one that we've used a lot over the years, and the evidence is kind of a bit mixed, but a lot of people swear by it, is coenzyme Q10. So that is also one of these transporters for shuttling energy. And actually, it's very cheap. You can get it in most supermarkets in the UK and health food shops. Don't buy expensive versions of it. But a lot of people over the years have used it. It is again evidence in the sports science literature. So that's the other one. So a little bit of exercise build up, and Q10 is a logical thing to do. And if you're in North America, go to your local muscle building shop and get some S-N-sarmethionine and see what happens. These are incredibly safe things. They're all vitamins.
How much coenzyme Q10, David? How much a day?
Yeah, so the one thing it can do is it can cause a lot of reflux. So people can end up getting nasty reflux. So it tends to be sold in 10s and 30s. When we did a trial in it, which showed results, and then it didn't replicate and all of that, which is why it's mixed. 10 milligrams is probably too little. So 30 milligrams or 60 is probably what I would use. So we used 120 and got a lot of reflex. So I would use 30 or 60. And for those of you in the UK, it's available on, 3 for the price of 2 at, Tesco's and Morrison's and these places. So it ends up about £3 or £4 a month. So it's not expensive.
So then with food then, David, if it's going to cause reflux with food?
Sorry?
With food then, if it's going to cause reflux in some people, better with food. Yeah. Okay.
Yeah.
Good. Thank you.
And it's a physiological thing. As I say, it's well known to be able to slightly increase exercise capacity because it makes energy generation more effective.
All right, thank you. And so the opposite of that is kind of rhythmic fatigue, where you kind of hit have a fatigue at the same time each day. Is there anything that can be done to challenge that?
So I think it's the same. It's the same. The likelihood with that, the likelihood with that is that it's in a sense the same burden during each day. So you're reaching the same. You're hitting the same problem because you've overdrawn. It's like overdrawing the bank at the end of the month. Is that you're hitting the same point each time with it. I mean, there is interesting things about circadian rhythm. So these are the night and day cycles that people have. Those are disturbed. And the sleep disturbance in PBC is funny because people tend to be sleepy during the day and then struggle to sleep at night. So there is I call it black and white. Normally you're asleep at night, that's black. You're awake during the day, that's white. But in PBC, sometimes it's lighter grey and darker grey. And so there may be an element of that. And one thing to just avoid is to avoid sleeping tablets and things to try and get you to sleep. What they do is have a horrible hangover the next day and you end up in a vicious cycle. So where you're getting a rhythmic thing, you always think, unless it's kind of very much associated with working week, so you work during the week and hit the wall at the same time, but at the weekends you're better, then if it's all the time, then you do wonder if it's part of the sleep-wake cycle. And the first thing to do before you go down the sleep clinic point of view is to look at whether or not you've got any stimulants that you're taking in the evening. So I'm very sensitive to these things. I can't drink coffee after lunchtime, otherwise it affects my sleep at night. So people can be very sensitive to these things. And remember, it's a great British tradition. If you can't sleep at night, you go and get a cup of tea. Tea has more stimulants in it than caffeine. It's like drinking Red Bull. It's not the right thing to do. So just have a look at the drugs you're taking. Make sure nothing that you're taking in the evening is then stopping your sleep. So it's what we call sleep hygiene. But it's complicated. If it's absolutely rhythmic, you feel like it's circadian rhythm in some way, and it's therefore sleep.
Perfect. Thank you very much. So I'm aware of time. I have 3 questions that I'd love to get in if at all possible. One, in terms of OCA and intervention, when is early enough and when's too late?
Okay, so you have to split between orthodox use and experimental. Okay, so orthodox use, it should be used after people have failed urso therapy. That's where it's approved for. But what I say is a year and a day. So you should be taking it a year and a day after you were diagnosed with PBC, because on day 1 you should have been given urso, and a year and a day you've had a year of urso. So the first thing you find is there's a lot of soft time loss. So people coming back to have their LFTs checked in 6 months to make sure they've really got PBC, and then just to be sure, another 6 months, and they give them a couple of years of urso, and all of a sudden it's 3 or 4 years down the line. So the first thing to do within the current model is to speed the whole thing up. And believe me, if you haven't responded to urso at 12 months you're not going to respond, down the line. So I think that's the first important thing. For experimental, we don't know at the moment. It's difficult to extrapolate from the mice to humans. So in the mice, it works provided you give it within the equivalent of about 4 months to 6 months of the disease. The $64 million question is do you ever see people with PBC early enough? And so in the first instance, the trial will be to give it to people with symptoms at the point of diagnosis, okay? So it will be primary therapy along with urso, okay? And it will also have some interesting aspects, which does it switch the disease off as well. What I can tell you, those brain tests about memory tests and concentration and faces and things like that, those are not abnormal in people who are AMA positive but have normal liver. So it is the onset of PBC that does it. So we have found the earliest point in the disease process. So the trial will look at, straight after diagnosis in people, and the goal of treating the symptoms in people who've got the symptoms. So perfect. The earlier the better, but if you're going to have OCA, or second line therapy, don't wait and wait and wait and wait. If it hasn't responded to urso, in a year, it's not going to. And there is too much time lost. This is my point about the only 40% of clinicians understand how to use second line therapy. There's too much time lost. And Marco may have showed you earlier, his work shows that the longer you wait to start urso, the less likely it is to work. And that is probably true for all drugs. So speed it all up, guys. That's not you guys, that's the doctors.
So I'll take your words to heart. So speed it up. A very last question. Literally, we just have 1 minute now. But somebody, so it's a common problem. Somebody with fatigue, having issues at work, they go to the GP or the consultant and say, look, the fatigue's an issue for me. Can you write a letter of support?
Yeah.
And then, well, there is PBC, but then it's often hard to define, or it's hard to measure, or those kind of unhelpful phrases. So what can we do?
So we write a lot of these letters, and we find that good employers take them on board. And we've got some wonderful stories of people who have moved off night shifts onto day shifts, from focusing in the morning and able to contribute to the organisations. And actually, everyone wins. The patient wins, but the company wins as well, because they're an enlightened employer and they lose a value. They keep a valued employee. What I would say is that things like the PBC 40. So if people are interested in the PBC 40, if you go to www.uk -pbc.com, okay, Jess Layton can check that. That's the website for UK PBC. And if you go to resources, okay, you can find the PBC 40, and then it tells you how to score it, okay. Now, we would not normally use that in the clinic because it's clunky, and in a sense, how people feel is how people feel. But if employers are being difficult, then print that off. And you can work out how bad your fatigue is. So the data's all in there, and we would measure PBC 40 fatigue scores and present that to employers to give some evidence behind it. So the guidelines now accept that fatigue is a part of PBC and it needs to be assessed and managed. The PBC 40 can tell you how bad it is, and if in doubt, it's the sort of thing. We're happy to give email for that sort of thing, give email advice and look at scores and things. And I'm sure the foundation are as well. Yeah. But don't end up in an argument. Yes, you get fatigue. No, you don't get fatigue. Quantify it. And that's the only clinical time I'd use the PBC 40. And if you're in the severe fatigue group, then, that is, widely accepted as a significant problem. And we have to say have very little difficulty, and we take quite a robust line, as you might imagine, with this, but we have very little difficulty in getting allowance to be made for this in the UK system. It flares up from time to time, but with the foundation and the other patient groups, we do a lot of this sort of stuff, and we find it's not usually a problem.
Yeah, fantastic. So just a very quick plug to say that the PBC 10, which is the baby brother tool in the app. The app. Other than that, I need to say a very quick thank you to Jess Layton, who's been scrolling for us and putting the detail in. Everyone who's joined us from all around the world. We've had Mexico, US, Canada, all across Europe and into Australia, all at the same time today, right now as we speak. So I'm going to hand over to Chief to say thanks.
Yes, I'm going to say thank you, Jess. You're a dream, wonderful. David will get you some chocolates, and don't give him one. David, thank you so much again. Robert, listen, you're playing the stormer. We're all behind you today. I'm going to do the kilt walk. Movement is medicine. I'll see you all later. Thank you, everybody.
Okay,
thank
bye,
you.
everybody.
Bye.
Thanks very much, everybody. Dave, great. Thank you. And on that note, we thank Jess for all her input today, and we shall see you for the next session very shortly. Thank you very much.